Okay, so many of you have asked so many times on the channel that please make a video on how to examine a neurology patient in the emergency or in the ICU when you're seeing for the first time. So how we can communicate with that. So based on that, I was having a discussion with Dr. Sushant, who is a neurologist with us, and he is very passionate about teaching and academics. So he volunteered that he will have a session, he will give a session on how to examine a neurology patient when it comes to emergency and ICU, and how the new trainees or new doctors or staff or those who are already working in those departments, they can properly examine and communicate to the consultant or in charge, or to whom, whichever team they are communicating. So please bear with me. My voice is not coming very nicely today. There is a URI. And with us is Dr. Sumit. He will act as a subject, as a patient for that matter. And today I will not speak much. I will hand over to Dr. Sushant. And again, thanks to him for giving us time on this busy day. Okay, Sushant. You can explain.
Good evening, friends. I am Dr. Sushant Eldasani, consultant with Apollo Hospital, Indore. So a lot of time we have problems with new joinees, the nursing staff, the RMOs and duty doctors, who tend to have not a good knack about the neurological examination, and sometimes the message is not conveyed properly. So the aim of this video is to teach the quick and brisk neurological examination, whether in an ICU setup or an emergency setup, so that it can be conveyed quickly to the consultant in charge, how to initially localize, examine and reach a preliminary diagnosis, so that it can be conveyed to the consultant in charge on time. And as we know, in neurology, time is brain. So as fast and as accurate we are, the better results we'll be able to give to our patients. So today,
just a brief point. So this is not a complete neurological examination,
yes,
which you see in an OPD basis when your patient comes to an OPD and you totally examine the patient. But at the same time, this is very, very essential examination which everybody should understand. And if you do this, most of the time will you reach to a diagnosis and will communicate in a better way, so that the patient management can be planned accordingly. So it's very, very essential. And again,
so yeah, this is a cursory examination. We will make a detailed video of systemic neurological examination if you like this video of ours. Thank you.
Okay.
So as soon as the patient comes to the emergency room or an ICU, the first thing after stabilizing his airway, breathing, circulation, ABC, is to go for the mentation, the sensorium of the patient. So sensorium of the patient is defined by the level of consciousness. So when I talk about consciousness, consciousness is the relative alertness of a person regarding himself and the surroundings. So we need to find out how conscious is the patient. And there are few terms such as drowsiness, lethargy, stupor, obtundation, coma, semi-coma. All these terminologies are very confusing, are very jumbled up. So I'll try to clarify each and every terminology so that we classify the patient on the basis if the patient is conscious, he is lethargic, he is stuporous, he is obtunded or comatose. So a fully conscious patient is alert about himself and the surroundings. He responds to the questions very aptly, briskly, follows the command when you ask him to lift the limbs, show his tongue, tell his name, he is fluent. He may have a bit of dysarthria, that is difficulty in speech or slurring, but that depends on the etiology of the neurological condition. But overall, a conscious patient will be alert, awake. You will require no major stimulus to arouse him. He will follow the commands, respond to the stimulus, respond to the question in an apt and appropriate manner.
So he is aware of the surroundings.
He is aware of himself and the surrounding and what's going on with him.
Okay.
The next category is lethargy or drowsy. In this, the patient is not in his fully alert sensorium. The patient might sleep. We require gentle stimulus. Gentle stimulus, when I say, maybe a voice, a loud voice, to make him arouse. Whenever we ask questions, he will ask he will answer appropriately. There might be few jumbling of words, but overall the responses are appropriate. The responses are less brisk as compared to a fully alert state, but then he follows the command, follows the simple commands such as moving of limbs, raising of hands, raising of legs. But as soon as we stop the stimulus, the patient might again go to the sleep. So this is the lethargy or a drowsy state.
And when it's sleepy, patient is sleepy but arousable on commands or stimulus.
Yes, patient is, although he's sleepy, a bit less from the alert state, but when we give him simple stimulus such as voice, he is arousable, he follows the command, answers appropriately, but then again goes back to sleep when the stimulus is...
Okay.
The next state is a state of obtundation. The patient is obtunded. In this, the patient may not respond to the voice or vocal stimuli, and we require some gentle shaking of the patient to make him awake. In this, the responses are not as brisk as it was in the lethargy or maybe the fully alert state, but still there may be some words which might be incoherent, incomprehensible. There may be few purposeful movements of the limbs, but then again, this is a severe altered sensorium state than a lethargy or a drowsy state.
So this obtunded patient will not become conscious on simple stimulus?
No, this requires some rigorous stimulus, such as physical stimulus is required.
And what is the difference between lethargy and drowsiness for the...
Lethargy and drowsiness are somewhat the similar terminologies. Yes.
Okay.
Drowsy, actually the term drowsy is a layman term which covers the entire state of altered sensorium. Okay. We specifically use lethargic state for better clinical evaluation and understanding the high mental function. Yes. Next phase is a phase of stuporous state. In stuporous, there is a significant decrease in the sensorium. No matter how vigorous you shake, there is only a simple hand movements. Patient may not be able to raise his hands above the bed. They may mumble, but they are not comprehensible. There may be few incoherent sounds which we are not able to understand. And overall, the patient is in a deep state of sedation or drowsiness in the stuporous phase.
So you have conscious, lethargic,
stuporous, obtundation and stuporous. And the last is comatose phase, where no matter what stimulus you give to the patient, you may vigorously shake him up, helping moving him from the bed, there will be no motor or verbal responses.
Okay.
So these are the four major terminologies which we use apart from the objective examination of the patient to know his higher mental function status, to know his sense of alertness, awareness, that is consciousness, lethargy or drowsiness, obtundation, stuporous and comatose.
Okay. Okay. So this is about higher mental function.
Yes.
So means when the patient comes, so whether the patient is lethargic or patient is obtunded, we'll figure out, we'll communicate in that language. Okay.
So once we have a basic degree of idea about the mentation of the patient, we go to a much more objective pattern, which is the most commonly used scale across all the emergency areas and the ICUs, which is the Glasgow Coma scale.
Okay, GCS.
GCS. So the Glasgow Coma scale is a scale of 15 points, which includes eye responses, verbal responses and best motor responses, which are categorized in further different categories. For example, if we talk about the eye, we have scale of 4, that is eye, patient is alert, awake, widely open his eyes. Second is opening eyes on verbal stimulus. For example, if I take his name, Sumit might open his eyes, that is E3. E2, patient requires vigorous stimulus, maybe some sternal pressure or a supraorbital pressure to wake him up, and E1 is no eye opening at all. Sometimes we may see a patient may open his eyes, but these are the non-purposeful eye movements. For example, in certain states of altered sensorium, in stage of lethargy, the patient may open his eyes. In certain infarcts, the patient may open his eyes and we may feel that he's E4 status. But if the movement and the responsive of eye is a non-purposeful response, then this will not be an E4, it will be an E2 response.
Acha, means patient is open the eyes, but they're not fixing the gaze.
Not fixing the gaze, not following the commands, not tracking the movements, not responding to threats also.
So we'll count it as E2.
E2. This will not be an E4, which is generally for a fully opened eye with a great level of consciousness.
Okay.
So the next is the verbal. So verbal also be divided into the 5 points. The first point is the patient is conscious, oriented, talking. In second, the patient is confused, but he may utter some words which we understand, which are meaningful. In V3, then there is incomprehensible words, although the patient is speaking on stimulus, but the words what he is speaking is incomprehensible. In V2, then patient is not able to speak, there is no actual vocalizations, but then there are certain sounds that patient try to make and which are incoherent sounds. So we put it as V2, and in V1 there is no vocalization at all.
V5 means the patient is vocalizing properly. And V4 disoriented. V3 incomprehensible words. You are able to understand the words, but the words are not
fully. There is slurring, or you may not even understand the word. The patient is speaking. The patient wants to speak. The patient is speaking, but you are not understanding the words.
But you are getting an idea that this is some word that is speaking. And in V2 there is some sounds. But they are not words per se. And V1 obviously no verbal response.
Coming to the best motor response, when I say the best motor response, we need to check the healthier side. For example, in majority of the neurological patients might have stroke. So they might have an hemiplegic or a hemiparetic side. That side won't move as much stimulus you want. So in that case, we need to see the movement of the best side. So we use the best motor response. And this also we grade into the 6 categories. In first, the patient is conscious, he is following the commands. If I ask him to raise his hand, he is raising his hand. If I ask him to move his tongue, he is moving his tongue. So that is M6. In M5, there is a purposeful movement to the pain. For example, if I am inflicting a pain to the patient, there has to be a purposeful movement so that in that the patient tries to withdraw my hand from the pain. If I am giving a sternal pressure, the patient should bring his hand towards my hand and try to move it. So that is a purposeful response to the pain. That is an M5 response. In M4 response, the patient generally withdraws to pain. There is no purposeful, but he tries to move his body or his leg in order to withdraw from the pain. M3 is a decorticate posture where there is a flexion at the elbow joint. The hands are like this, but there is extension of the legs. And M2 is a decerebrating posture where there is extension of the arms at the elbow, there is extension of arms at the wrist, there is extension of the legs at the knee joint, at the ankle joint, and in M1 there is no movement at all.
M3 is decorticate, so it will be flexion like this, and M2 means there is a
decerebrate.
Decerebrate like
E
this.
for extension, decerebrate E for extension of the upper as well as the lower limb. So this is how we classify into the Glasgow Coma scale, and based on that, a fully conscious alert patient is given a points of 15. So we further divided into 11 to 15 mild, 7 to 11 moderate, and less than 7 a severe decrease in the GC scale.
So one very important point to everyone, those who are listening, many a times I have seen in the document that whenever patient comes, the spontaneously moving limbs, patient is moving spontaneously all 4 limbs. So how will you grade it into M5, M6? So understand, it is very, very important. M6 means the patient should follow your commands. When you ask to lift the hand, the patient should lift up the hand. If the patient is spontaneously moving the limbs, it doesn't come under any category. M5 means localizing to pain. If you are giving a pain to the patient, purposefully it should come and remove that pain. So spontaneously moving all 4 limbs is good for documentation, but it doesn't come under any GCS category.
Yes.
Motor response.
Yes.
So you need to be specific, following, localizing, withdrawing, and then decorticate, decerebrate.
So there is a caveat to this. A patient who is quadriparesis, maybe of spinal trauma, injury, Guillain-Barré syndrome, peripheral neuropathy, who's not able to move his all four limbs. But then if we have to grade the patient to M6, we look at the eye movements. If the patient has a good tracking movements and he follows the commands from his eye and the facial grooming, then that patient will categorize as an M6 patient, even if his movements of limbs are not there.
Means M6 means patient is understanding what you're saying and patient is able to motorly move some part of the body on your command. So that is important. So quadriparesis can't move all four limbs, but protruding the tongue, moving eyeballs as per your command. So this is M6.
Yeah. So now once we have categorized the patient's higher mental function into the lethargy, drowsy, alert state, objectively defined the higher mental of the function according to the Glasgow Coma scale, we move further, which helps us to narrow down our diagnosis to a specific organ system or a local structural localization in the brain. So for that I'll ask Dr. Sumit to please lie down.
And I'll be moving the camera. We'll take care of
So
that.
yeah, spine.
Okay. I'll moving the camera, so I may not be visible in that.
So Dr. Sumit?
You can lie down.
Yeah.
Just a second.
So before proceeding with any further examination, we need to make sure that the patient's spine is stabilized. A patient with a trauma to head, trauma to spine should be given cervical heart collar and spine should be stabilized before proceeding further. So considering Dr. Sumit has no spinal issues and his spine is fully stabilized, I would like to further go ahead with my examination.
There are some scales used for ruling out whether like Canadian C-spine rule or Nexus scoring system. So there are few scoring system to rule out the spine, but the tip is until unless you have objectively rule out on the imaging that the spine is okay, put in a heart collar for that matter.
Yeah. So we've done
In
this
trauma
further examination and our video with full consent of Dr. Sumit. So first we'll rule out the neck stiffness. Gently flex the neck, make the chin touch to either your hand or the patient's sternum. There should be no resistance to it.
Okay.
Also try moving in
By.
different directions sideways so that we get to know that there is no neck stiffness or any signs of meningeal irritation.
Okay.
There are other signs of meningeal irritation which we might need to check. That is the Kernick sign, which we'll tell you when we talk about the detailed neurological examination.
Okay.
So once we have checked the mentation, the spine, the neck irritation, the signs of meningeal irritation, the most important neurological step is now the pupils, because only by examining the pupils we get a lot of information, not only about the condition of the patient, we will able to get the prognosis of the patient, we might able to localize which brain structure is characteristically involved due to in the present scenario. So I would like to have a torch with me. Make sure whenever you are examining the pupil, you examine with a torch, with a white or a yellow light, but not through your mobile light.
And it's a focused light actually. Bring from the side and then see. Okay.
So as we see, Dr. Sumit's pupils are both normal, equally reacting, have a good brisk response to light. So why this is important is because pupil reaction follows a path which goes from the nerves to ciliary ganglion to the Edinger-Westphal nucleus in the midbrain. So intactness of the pupillary reaction also tells about the intactness of the midbrain or the brainstem, which is the most important and the delicate system in our central nervous system. And intactness of brainstem or midbrain also helps to narrow down our diagnosis. So there are different types of pupils in different neurological conditions, which I'll tell. For example, we may have a fixed large dilated pupil which shows that there is some pressure on the brainstem, midbrain. There might be an herniation, there might be a tectal compression which cause the unilateral pupil of one side to dilate. Unilateral dilatation of pupil, one side dilatation of the pupil, shows raised intracranial pressure, herniation on the same ipsilateral side where the pupil is dilated.
It's an emergency.
It's an call for an emergency, either medically or surgical decompression should be carried out. Sometimes pupils are also enlarged in absence of raised intracranial pressure, and that's the problem which we face on a regular basis. That is if there is a third nerve involvement. The third nerve, as you know, arises from the midbrain. So if there is a midbrain lesion, if there is a third nerve lesion, in that case also you may find the pupil fixed and dilated, but in that you will also find the other causes of cause in which the intracranial pressure is not raised.
Patient may
so
be
we
conscious.
need to differentiate the dilatation of the pupil due to the raised intracranial pressure, in which the patient will be either a stuporous or an obtundate state. On the other hand, a patient with an isolated third nerve palsy whose pupil are dilated, ipsilateral pupil are dilated, may be not that altered as compared to the patient with the raised intracranial pressure. So what is important is we differentiate the dilatation of the pupil. In this, I would like to first tell about the anisocoria, which is the dilatation of the pupil. The inequality of the pupil is known as anisocoria. So there is a physiological anisocoria and there is a pathological anisocoria. So physiological anisocoria means that there is an ambiguity of around 0.5 to 1 mm in the two pupils, but the overall pupil size is not more than 2 millimeters. For example, we have one pupil of 0.5 mm and another pupil of 1.5 mm. This will be still counted as a physiological anisocoria, but not a very alarming sign, as both the pupils are less than 2 mm. On the contrary, if one pupil is around 1 mm and another pupil is around 3 mm, then that is a sign of some neurological disorders, because that becomes a pathological anisocoria. Other pupil signs: pinpoint pupil. When I say about pinpoint pupil, we see a small less than 0.5 mm pupil which is not very reacting, marked towards involvement of the pontine lesion, maybe a pontine bleed or pontine stroke or a pontine tumor. So this is how, on the basis of the pupil, we narrow down our diagnosis toward the either the brainstem, the midbrain pathology, the pontine pathology, or the more gross, the raised intracranial pressure, which may transdence or which may leads to herniation and the pressure on the brainstem and the tectal area.
So what is important is when we are doing a quick examination of the pupils, you need to understand whether there is an anisocoria, there is a pupillary size difference between both the pupils or not, and whether they are reacting to light or not.
Yes.
Just because they are unequal, you should also mention that they are not reacting to light or reacting
reaction
to light.
of light is utmost important, and for what I showed, that go from lateral to medial, go a focused light, a torch light, and see the briskness of the pupil reaction.
So we have higher mentation, then we did a GCS objective scoring, then we cleared the spine, and then we did the pupil.
Along with pupil, we may also see the extraocular movements. We see the movements of eyeball in all the direction. So what we do is, we ask the patient, in this case Dr. Sumit, to follow our finger laterally, left, right, up and down. All the movements are full and directed to the point.
So what this is of significance?
Intactness of extraocular movements suggests intactness of the various cranial nerves. The 3, 4th and 6th cranial nerves are intact. So by just looking at the pupils in eye, we get information about intactness of the brainstem, intactness of the cranial nerves, and intactness of the overall cerebral system.
So we have covered the higher mentation,
function,
GCS, then neck,
pupils, cursory cranial nerve examination. Now we go to the motor system, the power, basically, because I ask my residents how is the power, is the patient raising his leg, because this is important when we need to thrombolize a patient who present to us with the stroke. So what is important is the power of the patient prior to thrombolysis and the power of the patient after thrombolysis. So accurate diagnosis of the power, the tone, the motor system examination is very important for a clinical diagnosis in a neurological case and to decide the investigation and further management. So when I talk about power, motor system examination, the first thing which I like to examine is the tone of the patient. Tone is the resting state of the muscles. We examine tone in the upper limb, we examine tone in the lower limbs. Although there are tens of methods of examination of the tone in emergency and ICU when we have a time constraint. So we quickly examine the tone in the best possible method which we know, which helps us for a diagnosis. So coming to upper limb, we examine in the tone of the proximal muscles and the distal muscles. So distal muscles, we hold the hand of the patient and then we move like this.
In a rotatory movement, huh?
Or you can either do a handshake and check the tone, whether the tone is increased or it is flabby or hypotonia. Similarly, in case of upper proximal muscles, just do a simple flexion extension at the elbow joint. As we know, Dr. Sumit is alright, healthy doctor. His tone is normal.
Okay. And then we have to check the shoulder also?
No, I think for cursory proximal, we can examine by the flexion extension at the elbow joint, and
Same has to be repeated on the
same has to be replicated on the
opposite.
other contralateral side also.
Okay.
All the neurological examination should not be restricted to the one side. Both the sides should be checked.
Okay.
In the lower limbs, we gently check by moving the leg to and fro.
Medial to lateral and rotatory movement.
Rotatory
This gives you a brief little idea how is the tone.
Second, just put the hand behind the thighs and give it a lift. A patient with normal or flabby tone will just leave the leg, and the patient will high tone, says Dr. Sumit is tightening, maybe he's a bit apprehensive. We need to ask the patient to relax in case the patient is conscious, and then gently lift to check the tone. Similarly, tone of the lower limb muscles can be checked by flexion, plantar flexion and dorsiflexion of the ankle joint. So once we have an idea about the basic tone of the patient, hypotonia and hypertonia, half of our neurological diagnosis of an upper motor neuron lesion or a lower motor neuron lesion is being made just by looking at the tone of the
So how this is made? Because in upper motor neuron
in
lesion,
generally upper motor neuron lesion, the patients will have an increased tone, which we called as an hypertonia or a spastic condition, whereas a lower motor neuron lesion may have a flaccid or a flabby tone and a decreased tone, which we call as a hypotonic.
so in upper motor neuron, because the inhibition is gone, so there will be hypertonia is there.
They will have a spasticity or hypertonia, and in lower motor neuron lesions they will have
flaccid.
we for this tone we have a separate video
Okay.
which we will definitely post after
If you all want,
this.
make a request in the comments. Okay. So we have done the tone part.
So once we have a knowledge about the tone of the patient, we go to the power, checking of the power. So neurological power grading is done in 5 scales. Okay, the 5th scale, this points range is from 1 to 5. 1, 2, 3, 4 minus, 4, 4 plus and 5.
Okay.
These are the gradings in which we categorize the power in the neurological system during a neurological examination. So when I talk about power grade 1, it means actually a power in which there is only a flicker of muscles. There is mild flickering will be there, no specific movement. Grade 2 is movement eliminating the gravity. Grade
It's like
3
this.
like the horizontal leg. So
This
if I talk about the lower limb muscles and the patient has power 2, so I ask Dr. Sumit, please पैर को थोड़ा सा lateral ले जाओ. So
Okay.
this is.
Move the.
So patient will move the leg alongside the bed, but without raising it.
This is with gravity, not against
This
the
is
gravity.
eliminating gravity.
Yeah.
Eliminating gravity. Please move the leg towards right, and then move it towards you. Yeah,
Okay.
like this. Similarly, in upper limb, if you want to check the grade 2 power, ये हाथ को यहाँ side में ले जाओ, and then towards you. Yeah, towards you again. So this is Grade 2 upper limb power. Grade 3 power is power against gravity without any resistance. I'll ask the patient to raise his leg up. Can you please raise your leg up? Like this.
Okay.
So this is grade 3 power. In grade 4, again we categorize into 4 minus, 4, 4 plus, depend upon the power of the patient against the resistance. So gently put your hand on leg and ask the patient to raise the leg up. Kindly raise the leg up. So see. So in this case, as again Dr. Sumit, a healthy doctor with us, full bulky, has power grade of 5 by 5. So he is resisting the utmost pressure that I am applying. Please raise your leg. See, as you can see, I am applying all the pressure, all the power that I have, but still he is resisting. That means he has a power of grade 5 by 5 and
So
lower.
what is 4?
So 4 is power against movement of limb against gravity, but with resistance.
Okay.
The category of resistance goes from mild, moderate to severe, and in grade 5, the movement with full resistance.
Okay.
And then 0 power, power with there is no movement of him, there is no flicker. So we go from 0, no power, to grade 1, there is mild flickering. Grade 2 is movement eliminating the gravity. Grade 3, movement against the gravity without any resistance. Grade 4 divided again into 4 minus, 4, 4 plus, and then grade 5, complete movement of the power of the limbs with normal power. So as we've seen in lower limbs, we might see in the upper limb also. In upper limb, I'll take an example of the most commonly checked muscle, which is a bicep muscle. Okay. So bicep, when I asked Dr. Sumit to flex the muscle, flex. So this is grade 3. He's moving against the gravity without any resistance. A bit of resistance I will put here, and I'll again ask him to flex the elbow. And as you can see, this is grade 5 by 5 power, where he's able to flex it with against full resistance.
So in grade 2, how will moving the limbs from side to side?
Moving the limbs from side to side.
Okay.
Like the elbow will be here. There is no gravity involved. It doesn't raise from the bed, and we asked him to move like side to side. So
Okay.
this is
One
grade 2 power. But usually whenever in emergency, because we have a time constraint and we do not want a definitive and pinpoint power, we just usually ask patient to raise the leg up. If he is raising the leg up, the power is usually 3 and above. If he is not, then the power is either 2 or 1, or maybe 0 if he is not moving in legs. So once we have categorized the tone and the power, we move on to the reflexes, the deep tendon and the superficial reflexes. Deep tendon reflexes, DTRs, are most important when we examine or localize the patient. So I'll just show you brief how to examine the reflexes and their respective root values.
Okay. So this is important. So this is important whenever you are testing the reflexes. So very important that which root you are testing, that is important. Means in reflexes you are testing the root of the spinal cord,
Yeah.
and they should be checked on both the sides.
So before I jump onto reflexes, I want to tell you that the reflexes depend on the condition of the patient, on the age of the patient, on the amount of anxiety the patient has. So before examining, if he is a fully conscious alert patient, we just need to relax him, make sure he is calm, and then proceed with the examination of the reflexes. So first reflex which we'll examine is the biceps reflex. We put our finger on the tendon, gently percuss it, and we see the flexion of the forearm. The root value of the biceps reflex is C5 to C6. So whenever I percuss, the nerve root goes to the C5, relay the signal in the spinal center, and then come through the C6, which we see the flexion of the bicep.
So
similarly, there is a wrist reflex with root value same as that of the biceps. Gently hit the supinated tendon over here, and we can see.
So we have checked C6 level.
C5, C6, yes. So next reflex is a triceps reflex. This is a tricep tendon just above the olecranon process, and I gently tap, and as you can see, there is movement of the triceps muscle.
Okay.
With root value of C6 to C7. So where this is important in case of spinal injuries, spinal trauma, in case of myelitis, we have to localize the lesion. We need to decide whether we want to get a cervical spine MRI or a dorsal spine MRI. So examining of the reflexes helps that in us. For example, if the patient's reflexes are normal, if he has a normal biceps, triceps, supinator reflex, I am sure that his cervical spine is okay, and then we proceed to the dorsal or the lumbar sacral spine imaging for that purpose of our diagnosis. Coming to the lower limbs, two most important reflexes: the patellar reflex, the knee reflex, and the ankle reflex. So for patellar reflex, gently flex the leg, keep one hand below the thigh, palpate the patellar tendon and see the movement. So the root value of the patellar tendon reflex or the knee reflex is L3, L4, which is seen by the activation of the quadricep muscle, which is responsible for the extension of the knee joint. Next is the ankle reflex. Ankle reflex, we gently plantar flex, dorsiflex the ankle, palpate the tendo-Achilles tendon and tap.
So there is a contraction here. You need to see the contraction here.
So try to expose the muscle.
You see that contraction is here.
So these are the reflexes, and the most important is the Babinski or the plantar reflex, which helps us again in the, as the pupils are important, which helps to tell the prognosis, the current condition of the patient. Even the Babinski and the plantar reflexes are important to tell the current condition and the prognosis. So to check the Babinski, we need to calm the patient down, keep talking to him so that he does not withdraw.
How to do it? Can you explain?
So we go from lateral to the medial, but not to the thumb. So we start from here, go to here and stop.
Yes. You see the movement of the thumb. Fingers, here.
Make sure that you do not touch the ball of the great toe, so that, because in that case then you will do the S2 reflex will be there. It will not be a true Babinski reflex. It might be a flexor response may be there due to irritation of the thumb, not due to the S1 root that we need to check.
They need to come to here only.
Come here, yeah. We start from the lateral, go towards the medial and then stop it.
Okay.
So Babinski, plantar reflex, plantar extensor, plantar flexor. Plantar extensors are important, as extensor plantar has again the pathological causes. The extensor plantar may be unilateral, may be bilateral. Unilateral plantar extensor shows that there is a corticospinal tract involvement on the ipsilateral side. Bilateral plantar reflexes, extensor plantar reflexes can be in cases of the bilateral cortical spinal involvement, in case of high cervical spinal injuries, sometimes in case of generalized encephalopathies, metabolic encephalopathies, septic encephalopathies, in which you have gross altered cerebrum structures, gross altered sensorium. In that case also you may get a bilateral extensor plantar. So plantar reflex in an emergency in ICU is of utmost importance, as important as seeing the pupil and the respiration of the patient, because it gives a very initial clue regarding the raised intracranial pressure or the deteriorating condition of the patient.
Okay, so now we'll come to sensory system.
Yeah, once we have examined the motor system, a quick sensory system. Generally the patient might be altered, so we might not get a definitive sensory examination done, but in certain cases of a myelitis or a peripheral neuropathy, or in case of hemiparesis, we need to check the intactness of the sensory system. So we do it with a pin. Make sure the pin is not sharp enough, not sharp that much so that it pierces the patient, used with a light pressure, and we check different dermatomes right from the C3 dermatomal to the C5, and then check various thumb, fingers, L3, L4, L5 and so in different dermatomes, so that we get a brief idea about the intactness of the system. Similarly, in the thoracic, the nipples at the level of T4, umbilicus at the level of T8, we keep on examining and localize the sensory deficit level.
You can ask for sensation and then from pinpointing from the pin also.
Yeah. So once we have done with the sensory system, if we are suspecting the cerebellar system in coordination, we ask the patient to do a quick finger-nose finger test, which helps us to identify. So Dr. Sumit, I'll just ask you to sit a bit so that I can check.
So this is when you are suspecting that there is a lesion in the cerebellum.
Cerebellum.
No. And just a quick info, those who want to see the dermatome routine.
Detailed dermatome, we might put it again, the detailed video of the sensory system examination in neurology.
But we had made a short ICU short on this. You can go in the link which is there in the bottom of this description of this video.
Fine. So to examine the cerebellum, we asked the patient to make a fist, make one finger like this, touch the nose, make sure the elbow is in this angle and touch my finger. So this is finger, nose, finger. So make sure that you keep on changing the position to get the accuracy, and repeat it with the both hands. When you are done with the right hand, similar examination needs to be done with the left hand.
Dr. Sumit is fine.
Fine, he is totally coordinate with all his responses. And next is gait. Generally, gait we check in a detailed neurological examination. We may check a few tandem gait or just see how is the stance and width. Gait, again, as I told you, is a different examination, a different video altogether. So we started from the mentation, the higher mental function, came to Glasgow Coma scale, spine, pupil, cranial nerves, breathing, the motor system examination, tone, power, reflexes, sensory, Babinski examination, coordination. So this is how the flow of examination should be done in an ICU or an emergency room setting. This helps us to, one, diagnose a patient, decrease our differentials to systems, helps us decide to the investigation and better inform to the consultant.
So Dr. Sushant, can I request you, in one or two scenarios like stroke patient, trauma or like GBS,
I'll give you a scenario of a stroke patient.
How to inform?
How to inform and how to examine, what you need to tell the consultant so that he understand, and what you yourself need to understand so that you can take a better step in taking the next step towards the investigation or the treatment. So for example, Mr. X, 50 years male, presented in the emergency with weakness of right upper and lower limbs since 1 hour. So this is the condition. This patient has come to you with, his wife is saying that he was absolutely alright 1 hour back when he was reading newspaper and suddenly he felt weakness in his right upper and lower limbs, and with this complaint the patient has come to you. So first you definitely need to examine his sensorium, how his sensorium is there. Is the patient conscious? Is he altered? Is he stuporous? Is he lethargic? Then after the mentation function, you need to identify the Glasgow Coma scale of the patient, because we yet not know the diagnosis. He might have a large bleed, he might have a large stroke, so we need to categorize him in the Glasgow Coma scale by seeing his eye, his verbal responses, his best motor responses. Look for the pupil reactivity. First, look for the signs of the raised intracranial pressure. In certain cases, a patient with stroke may have a large bleed or a large stroke causing herniation. So just look at the pupils. Is there is asymmetry of the pupil, any nystagmus movement, any rotatory movements. See how the pupils are there, the pupils are reacting or not. Then come to the motor system examination. He might have the hemiparesis or a decrease in power in one side. In our case, he has a right upper limb, lower limb weakness. Categorize the power according to the scales from 0 to 5 that I have told you earlier. Check for the Babinski or the plantar response. In this case, you might get a unilateral, in case of right hemiparesis, a unilateral extensor Babinski response. Check for the asymmetry of the sensory. Put a pin on the left side and then the right side, and you might get to know that there is an asymmetry of the responses. Summarize it, tell it to the consultant.
So what this helps you not only diagnosing but also monitoring the patient. So that suppose before thrombolysis it was the GCS, the power was 2, and now post thrombolysis the power has increased to 4. That means this is the thrombolysis is working. Similarly, in the case of GBS, like this, if the reflexes are absent in Guillain-Barré syndrome, reflexes usually absent, and now on the rounds you feel reflexes are coming, that means the therapy is working. What is the respiratory rate? Means if the power, the tone of the muscles, if the tone of the muscles is increasing, the respiration will become comfortable. So this is how you should summarize on case to case basis this minimum bare your thing. And once you have started doing this, you will be a better physician, you will be more confident in understanding, and you will be more confident in communicating and more confident in monitoring the situation. You will not panic over this.
Yes, because ultimately our aim is to provide maximum benefit to the patient along with us learning few things. So as these points, as you are confident about these points, as you know that what you are seeing, what you are localizing based on these points, as much as you will be confident in that we know what to see, what to expect, what to do, the better it will be for the patient.
So now go back to your textbooks, any clinical examination textbook. Now read the neurological examination, and then you will understand what we were telling. Why motor system involvement is important. Now when you go higher, when you read in detail, because there are lots of spinothalamic tracts or spinal tracts which are going in the spinal cord. So if the motor power is this and the sensory system is the same or not at that level, we can understand that lesion at which level in the spinal cord. These are which needs to be covered in detail video. But the point is, don't be crow-like system. Once you examine the people, then you jump to the reflexes, then going back.
Go step by step, and then finally summarize the findings and take action.
So hope this helps. And you have any doubts or any suggestions, do post in the comment section. And as Dr. Sushant already said that if you want a detailed video of his on detailed neurological examination, you need to post in the comment section. Only then he can spare the time. And
thank you, Dr. Sumit, for being a wonderful subject and cooperative and healthy subject.
So just for understanding, Dr. Sumit is a fellow in critical care. He is doing a critical care fellowship also. So now this would be helpful to you all. Thank you, and do read more about it. Thank you.